So let's talk about a little bit about the nodule, the case. So Rudy, let's.
Yes.
Or are going to wait a little bit?
Let's wait about 2 or 3 minutes, Dr. Rangel. Dr. Rangel, yeah, let's wait about 2 or 3 minutes more, and then we can start about the case and go from there. Okay.
Okay. Don't worry. So the image is okay.
If you wanna start right now, yeah, it's good image right there.
Okay, perfect. So guys, it's a pleasure to have you all here. This is my home in Rio de Janeiro. This is the State University of Rio. We are doing this case in the OR as a matter of recording and the procedure, but you can do this in the office, don't worry. So we have 3 screens. We have one screen into the neck of the patient, one showing the ultrasound, and the other one into the generator. 2 things that we have to quickly observe into the generator. The red 0 marks the watts being delivered to the nodule. So it varies along during the ablation time. And it varies with the 0, the yellow 0, that is the impedance. There is the resistance through which the energy is passing to the nodule. So as the impedance increases, the amount of energy decreases, okay? So we will start with 50 watts in this case, but we only deliver the 50 watts in the beginning, just the beginning. Another important thing that we have to observe is that is marking now the 9, the green 9, that is the temperature. It's marking in Celsius, as we use here in Brazil, but we have to use it as low as possible, okay? So these are the main things that we have to really be concerned about, okay?
Dr. Rangel, we had one question pop up through the Q&A. And I don't know if you're going to go through this as you go through this, but one of them was asking the markings on the neck. What are the markings on the neck, and what's the purpose and of that?
Oh, this is to make it easier. Let me show this. What is it? No, bota tampado. So this is something that I developed to make my case a little bit more reproducible. Okay, so here is the nodule. Okay, this is a hot nodule on the left side of this patient. Okay, it's a big nodule. This patient has a subclinical hyperthyroidism. So this is an excellent case for radiofrequency. So the marks are the follow. So I can check the whole nodule. I scan the nodule. So I go onto the inferior border edge of the nodule and I mark the inferior edge. I go to the superior mark portion of the nodule and I mark here. I use the midline, the mid portion of these 2 lines. So I make another horizontal line, and I check if which position of this horizontal line I can make my my insertion points more efficient, so I can reach the whole nodule with just one single skin puncture. Okay, so I can predict it where I can put it, because if I put here, my insertion will be too far from the nodule, or if I put here, it will be easier to reach in the inferior part, but it will be harder because of the clavicle or something like this, or the breast, to reach the superior part. So this way I can use I can predict where I can really put all my incisions. I also mark, we can, Fabiola, olha pouquinho pro lado aqui para cá assim. I don't know if you can see, there is also a mark here that I generally I put this incision. So sometimes I have to do some hydrodissection from the lateral in this portion, and sometimes I use a lateral puncture here. So we are going to go through this. This is some kind of systematization that I put together. We published this on Video Endocrinology. So if you guys want to see this more detailed and
yeah,
okay. So, but it's a way you can predict and plan your procedure ahead of the time. So this I do with the before, and then I prep the neck. Okay.
perfect. Thank you, doctor.
Well, so I told you about the case. So this perfect nodule. She has a TSH of 0.5 and with a normal T4. So and she has a scan with a hot nodule on the left side. So let's start it, Rui?
Yeah, let's begin. It's 9:10 already, you know, so let's begin.
Okay. So first we start with the lidocaine, okay? Small needle, insulin needles, just for the skin, okay? So as we have marked the position already, we just do the subcutaneous, okay? Espetadinho. Guardei pouquinho, tá? Com anestésia. Just a small one, small button, okay? In the subcutaneous. And also on the lateral. So if we need to do the lateral. Espetadinho. Perfect. Now we use the 1% lidocaine without epinephrine, just to go and get the sub here. Okay. So this is a very critical and important part of the procedure. We go just above the capsule of the try to get here. Perfect. Vai arder pouquinho, tá? É só para anestesiar.
Dr. Rangel, the ultrasound image screen went off, the ultrasound video.
Sorry.
It's okay. Here we go.
Okay. Please remind me if something that's like this happens.
We'll do, sir.
Okay, so we go just over the capsule. Really try to. Now this is the area. Okay. This is. Try to really move the muscle and walk with the needle. So when we reach this part, it's perfect. We really can. And when you have this part, see that even in the inferior aspect, the lidocaine really went through the inferior. We didn't go a little bit in the superior part, so we scan here and move the position a little bit and get to the superior part. Okay, like this. Okay. Mais pouquinho de dedo.
A few questions, Dr. Rangel, that are coming across. What type of lidocaine is being used and what size is the needle?
This is a 22 gauge needle, 45 millimeters long. This is 1% lidocaine, okay? I try always to use 1% because sometimes you do, if the nodule is quite large, you can use a large volume. So here we are doing the superior part, okay? The superior edge of the nodule. As the nodule is a little bit...
Leo, this is Higino talking. How are you doing?
Hi, Higino. Hi, Higino.
Leo, there's a question about the inverted image of the ultrasound. Do you want to comment this?
Yeah, I'm doing the procedure on the head of the patient, okay? Yeah.
Yeah, it's good to comment.
So this is the position I find most comfortable, and because I can rest my elbows around the patient with the head, and I have the two hands freely, and I do it seated. I rather do this way than by the side of the patient because the back hurts a little bit if the procedure takes too long. So I invert the ultrasound position so I make it easier for me. But you can do it either way, okay? And now, as we are doing the lidocaine, we do just over the nodule, but it is quite important to reach over the carotid so we can hydrodissect a little bit of the carotid space so the patient feels no pain around the carotid. So, but along the carotid, sometimes it's hard. Sometimes you can block the vagus nerve and get some hoarseness just because of the lidocaine, not before the procedure. So when you go over the thyroid, we try to use the 5DW, okay? Here we use the 5DW.
You talked about the vagus nerve. I think it's important to talk to the patient to see if the voice is okay or if he has hoarseness, right?
Perfect.
To see
we have all the time. So see how I'm dissecting the space between the nodule and creating this space. Just a little bit of this water will create a safety cushion between the ablation area and the nodule. And this area goes a little bit inferior, the same position. When you reach the right spot, the water dissected. You don't have to move a lot, you know this position. I'm just injecting. Now I injected almost 15 cc's, okay, of 5DW. So I did the hydrodissection with the 5DW and over the capsule with the lidocaine, so the patient doesn't feel much. So I guess this is good for the start. If the patient complains a little bit, we can do more lidocaine as the procedure goes, okay? A pressão, né? A gente injetou, a gente vai, que é para você não sentir dor, tá? Mas é normal.
Na cabeça?
Na cabeça? Na cabeça pode estar um pouquinho, né? Tá muito tempo nessa posição, né? Isso, pode mexer um pouquinho. Hã? Pode falar.
No pescoço, na cabeça, atrás.
Ah, sim. É, porque a gente injetou um líquido para você não sentir dor durante o procedimento. So, this is the electrode, okay? The electrode, it has some landmarks during that are ultrasound sensitive, so you can see this as the procedure goes, the depth of the needle. And this is a mod 7 or de 10? This is a 10 millimeter active tip, okay?
Dr. Rangel, one quick question. Do you usually do DSW on every patient prior to the ablation near the carotid?
Não, essa pressão da cabeça.
Pressão na cabeça. Normal, é que tá. Exprimi realmente aqui, botei muito para você não sentir dor. Tá?
Do lado esquerdo,
Hã?
na cabeça, do lado esquerdo, na frontal.
É. So as we puncture here, we will always start with the most medial area of the nodule and most posterior. Okay, so we really have to tilt the electrode through the around the trachea. Okay, so just a sec. So one important safety measure is to always see the tip. Seeing the tip is paramount. Okay, if you do not see the tip, stop the ablation. Okay. Okay. Tip over there. Position. Vou começar. Pode sentir um pop.
Isso.
Pop. I didn't warn her. She when doing the procedure, we can use some pop and burning sensation in the nodule, okay? And so the patient doesn't get scared. Isso é normal, tá? Vai sentir. Sometimes you can even hear the pop. So whenever you see this hyperechoic halum, you can move, and you really need to take your time during the procedure. Sometimes you see the impedance going up. You move a little bit. If it takes and as this is a autonomous nodule, we really have to go to the edge of the nodule, so we can really take care of the entire nodule. Okay. Perfect. Position, and now reposition the electrode in the same plane, but in a further position, like this. See, when the impedance increases and the power decreases, it's time to change position. You can tilt a little bit like this and retract very slowly, giving time so the tissue can really burn. Really take your time. See the patient, it's completely calm. It doesn't take too much time.
Leo, there's another question. Explain how when you withdraw your needle. Show when you withdraw the needle.
Yeah, when we move the needle out and we move it superior, like more superficial, like this. Like this. Remember, always getting to the edge of the nodule, like this. Okay. So when we are done with this section of the nodule, see, we can always check the longitudinal aspect of the nodule. So can you see this middle section of the nodule that we just ablated? You can really see a column of hypoechogenicity that we did. So the superior part like this is not treated and the inferior part not treated, okay? So we move a little bit. Tem mais pouco de gel aqui, Brian. So let's check this area we treated. Let's move to an untreated area like this. So we see a normal tissue and needle again, inferior aspect close to the trachea like this, as close as we can to the trachea, and start. See the bubbles? When we get the bubbles, retract a little bit. Because when we get the bubbles, the temperature was, it's already, so I don't know if you can hear, but we saw some bubbles and popping in the tissue. When we get these bubbles, the temperature have risen above 100 degrees. We don't need the temperature so high. Pop, normal. We heard a pop. Susto. She got frightened because of the pop, but it's normal. She didn't feel pain. The pops sometimes get people jumpy like this. Don't worry. Always doing the procedure transistomic. This is why we do this, because if the patient moves or swallows, we don't have a problem because the needle always also moves with the swallowing, and we don't have this knife effect. And more superficial, close to the edge of the nodule like this, popping. See the hot liquid going around the nodule like this. Hot nodule, like this, like this. Perfect. Another section. Retreats the needle from the nodule. We get another untreated area, and we scan the nodule like this and move here. Like this, you know, tip of the needle, bubbles, Retreat.
tão grande assim.
É. She asked, she didn't know the nodule was so big. Yeah, the nodule is big. Capsule, stop ablation, move to the edge. Always see the electrode getting in to the nodule. Never move the electrode without seeing where it is. Okay, like this. Retreat. Retreat, no, retract. That is, retract. Never retreat. So whenever the impedance is high, try to tilt a little bit. So sometimes you get some crust around the electrode, okay? But, well,
O lugar que sai o nome, ele se regenera, como é que acontece?
depois eu te explico tudo direitinho, pode deixar. And the superficial area. The pop. Always warn the patient about some pops. It's quite frequent. Okay, so I guess we treated almost this whole area, this area here. I think we can take care a little bit more of this area. We really want to have a very hypoechoic nodule, okay? Like this, especially on those hot nodules, that our goal is not just to decrease the volume, but really treat the hyperthyroidism, okay? So don't be afraid to redo some areas that you feel you didn't treat completely, okay? That's why we really have to take care of the lidocaine and the hydrodissection before start the procedure. Because if the patient is comfortable, the procedure goes smoothly. Don't worry. Okay. So I think we are just about to end the procedure with the superior edge of the nodule here. So see how I use the same incision here. Let me change my hand so you can see. So I'm really tilting with the needle outside of the nodule. I will move the needle and get to the superior part of the nodule. Okay, boom. And get to the posterior part of the nodule. Pop. Pop. Essa área mais de cima, né? Aqui já acabou. Okay, so we move a little bit. This area here. Here, posterior aspect. here. This area I probably have ablated already, but the the nodule, and it's a little bit stiffer because probably you have ablated before, but in these cases uh, it's never too hard to ablate more than once. Don't worry, it's important to treat the whole nodule. And so see how different it is, the nodule right now. Extremely hyperechoic with some areas like this. And now we check, now is the tricky part. Now this is the thing that we really must pay attention. This is, we are going to put the Doppler. Aperta a cor ali para mim, por favor. Cor, embaixo da cor, embaixo. We are going to do the Doppler, okay? So this area, we have some artifacts because of the ablation, but we really have to check if there is some vascularization left. So we have some artifact because of the hot liquid still moving inside the nodule. But for example, here we have some vessel on the capsule of the nodule right there, okay? So that capsule must be treated. So inside of the nodule, I'm pretty satisfied, but in that lateral capsule of the nodule, we still have to take some caution because we don't want to have any revascularization of the nodule. So this is I'm going to do just for a demonstration how it works like this. So I'm going to get to the capsule like this. And let's get into the, like this, into the vessel, and we are going to ablate the vessel like this. You don't need to do this with the Doppler on. You can okay. And we remove the needle, okay? And the vascularization is over. A little bit upwards over the capsule. See that area. So it's a little bit of caution, but we really want to treat these areas, okay? So we don't have any regrowth afterwards. This is what they call vascular ablation. Sometimes you can do this before the procedure. Já tá acabando, já tá no finalzinho. Okay. And we can really track it with the impedance. When the impedance gets very high, we can stop. So we still have some movement effects because of the heat. Still some vessels over there.
Leo,
Hi, say Gino.
there's a question here. Can you elaborate more on the watts and the power and the impedance, how they change during the procedure?
Sure. So the impedance is the electrical resistance. Okay. So whenever the resistance gets up, the power that is the amount of energy that is entering the nodule get decreased. Okay. Here is our area very close to the trachea. I think I should take care a little bit more.
Hi, Leo. Congrats for
Hi.
the procedure. Erivelto speaking. I just take out my parathyroid and I'm back to the meeting.
Perfect. Tira a cor para mim ali, por favor. Bota no B. Perfect. Let's get at the B mode.
Leo, let me ask you, we discussed this already, but even for huge nodules, do you really prefer to do just one punction in the skin? Because yes.
Sometimes it is unavoidable. If the nodule is quite huge, we cannot do it with just one puncture. But if the nodule is in a reasonable size, sometimes I try to use just one. But this is why I think it is important, the systematization of how to take care of the before start the procedure, in marking these landmarks on the neck, because I think we are okay with the nodule. Just a second. Yeah. Okay, bota a cor novamente. Sorry guys. Let me just take care of the nodule. Then we can have more time for discussion. But so this is a longitudinal view of the nodule. Here. Okay, so I'm done. So just to finish here with just some ice packing here, a small bandage just on the puncture side, and it's done. Okay, acabou. Okay, foi tudo bem. So let's get some questions and look into this, so I can have the patient out of the OR and heading back to home. Não, deixa eu usar isso para me filmar. Não. Pode. You can't stop the recording process, okay? So like this.
Leo,
hi.
There's another question here. If you want to comment,
let's finish the Erivelto's question, because we didn't actually. So we can do more than one puncture. If the nodule is very large, if the nodule is very large, we can have more than one. We can have more than one puncture, entry puncture. We don't have to worry. We just have to measure it before starting. So we can make like one inferior puncture site for the mid part of the nodule and the inferior part, and one superior entry site for the mid part and the superior part. So you have to plan this ahead of the procedure. So if you start the procedure, it doesn't matter. After, if you plan this before, you don't have a problem with this. Okay. Say it, Higino. What do you want to ask?
So one of the other questions.
Hi.
Oh, sorry. Go
There's
ahead.
another question from the audience.
Tira o zoom.
Dr. Rangel, do you want to get rid of the ultrasound image? There we go. Do you want to get rid of your ultrasound video that's there? Dr. Volpin can start.
Okay, yeah.
Yeah. Dr. Volpin, if you want to turn on your camera, you can. But go ahead, Dr. Steck. Sorry.
Hi. Okay, there's another question from the audience that I think it's good to comment. The position that you take when the nodule is on the other side. There's two options. Sure.
Yeah. You can have the patient by your side. Let's have the patient. We still have the patient here on the OR. We can show the different positions that we can have the patient. Just a sec. For the ultrasound. Just a sec. Marcelo, vem para cá aqui. Aqui uma paciente aqui. Eu vou fazer aqui do lado. Fátima, deixa eu só mostrar aqui um negócio aqui. Deixa eu só. So, I am a left-handed surgeon. So, we can do the procedure, for example, on the right side of the nodule. I can hold the probe with the left hand and insert with this hand. But doing on the left side, I would go to the head of the patient and do the backwards. Okay, but if a right-handed surgeon, you could do with your right hand and stick the needle with the left for the left side nodule and do like this. But doing like this, Marcelo, mostra aqui eu aqui. Aperta o botão. Não, Marcelo. You can do like this, but it gets a little bit tiring to do the whole procedure like this. You may get a little bit tired. Doing by the head, I think it's the most comfortable position to do the procedure, but in the end, it's up to you the way you do it. Don't worry, you don't have a right way to do it. You do it the way it's more comfortable for you.
Great. Leo, another interesting question from the audience. It's what's the minimum and the maximum size for to perform RFA? Actually, I suppose you agree that there is no maximum size. There is the number of sessions needed to treat totally the nodule, right?
Right. In the end, it's about this, because we know that nodules over 4 cc's, they have a small volume reduction rate, but they do get decreased. So talking about normal benign nodules, if you have a nodule that is very large and we anticipate, for example, a 60% volume reduction rate, and we see that the volume that this nodule will end up is going to be huge in the end. For example, to be still a large nodule after a 60% reduction, and the patient will not be comfortable, or the problem with the neck bulging is not going to be solved with this. Maybe radio frequency is not that ideal, but for example, but you can repeat the procedure as much as you need. It doesn't really have a problem with that. But it's a matter of deciding. I think in the future we probably will have a guideline that will actually address that a growing nodule will be better addressed with radio frequency before it gets these huge sizes. So if we see a nodule that is growing, we will probably take care of it before it gets that size. But on the other hand, for example, a hot nodule like this one, you actually don't have a minimum size. For example, if you have a 1-2 centimeter autonomous nodule, you should take care of this nodule with radio frequency. It's better for the patient. When you do radioactive iodine ablation for those plumber diseases, in some cases you may have hypothyroidism after the procedure. With radio frequency, you cannot have hypothyroidism because you treat just the nodule, not the normal thyroid tissue. So it is a perfect treatment for those benign autonomous nodules.
Okay. There is another, because we perform RFA with small differences between us. One of the differences is that I suppose you do not do hydrodissection in all your cases.
Yeah, if the nodule is not big enough, or if the nodule is not close to trachea, it's a ischemic nodule, something like this, you may not need to do radiodissection. You don't need to do the hydrodissection up front. You can start the procedure, and if you feel the need to, and the patient complains a little bit, because when you get heat over the close to the carotid, the patient may experience some reflexive teeth or mandible pain for this reason. So when you do this hydrodissection, you can get rid of this reflexive pain. So it is an option. All these kind of things are some auxiliary methods that you can. It's on your disposal. It's on your disposal to use on several cases. As the cases get a little bit more challenging, for example, parathyroids, lymph nodes, things like that, you will need to use those auxiliary methods. So it is important to know them and get comfortable with them in these benign cases. So it is good to use on some, even if a little bit, on these small and benign cases, so we can really get comfortable and used to them when you need them. Okay.
Hi, Leo. There's another interesting question here. What do you do to avoid rupture of the nodule capsule? Did you try to stay a couple millimeters away from the edge, or it doesn't matter? In resume, what do you do to avoid the rupture of the nodule capsule?
One thing that I really try to do, and not just for rupturing the capsule, but for various safety reasons, is to increase with a low power. For example, this case, I used a 10 millimeter active tip. This 10 millimeter active tip will have a lower density of energy. So whenever the smaller the tip, more concentrated is the energy. So the less power you need. Whenever you use a larger tip and the larger the nodule, you can start with somewhat higher power, like 50, for example, as we started. But if you want to go faster or start with a very high power that I do not advise to, for example, 70 or 80 watts, the bubbles and the air dispersion that will cause with the energy, the heat of the tissue, may rupture the nodule capsule and may eventually cause some hemorrhage. I didn't have any so far. So, but as you saw, I really take my time doing the procedure. I am really slow with the ablation and really leave it burning. Okay, I have never had any capsular rupture, but also the low power at the start will allow you to avoid if this kind of bubbles that the patient feels and may get some worried and a little bit bumpy. You can take a little bit down. It's good because, as we saw, we start the ablation at the most dangerous part of the nodule because we start very close to the nerve. So you do not want to start with a very high power and do not know how to predict this energy is going to interact with the nodule. So we start with a low power and see how it goes and slowly increase with 5 or 10 watts intervals of increasing. Okay. Good question, Higino.
Another interesting question here is about the popping. If the patient only hear the pop, or if he can feel the pop.
They feel the pop. They see some like a popcorn.
It's like a popcorn, right?
It's like popcorn going up. Yeah.
Yeah.
Yeah. And we have to warn the patient up front so they do not get so bumpy. Okay, but it can happen. It doesn't need. If you hear the pop, you just over ablated a little bit. We should have stopped it a second before. But it's not. It's no harm. It's no harm on hearing the pop and having the pop. But we don't need to get the temperature to that high.
Okay. Another interesting question here is about what you see in the nodule after the ablation. If you see the hypoechoic or hyperechoic nodule. I think it's different in the moment that you do the ablation and what you see after a couple of weeks of the ablation, right?
Right. Immediately after the ablation, with the needle still inside, the tissue gets hyperechoic. But if the procedure takes a little bit, or as the procedure goes, the nodule is gets hypoechoic with some small dots. So when we start with a very isoechoic nodule, as we got there, as this one, in the end, we get a very hypoechoic with microcalcifications and very irregular nodule. So it's a very scary nodule after we end the procedure. So we really have to have this benign nature of the nodule very well taken care before the procedure, because afterwards the nodule will get shrink, a little bit rugged, and very hypoechoic.
Good.
Leo, are you hearing me?
Yeah.
And what about patients that use antiplatelet aggregator? How do you deal with them?
No, we have to stop them before, because sometimes we hit some anterior jugular vein or have some bleeding. We really want to avoid this kind of complications. Sometimes you have some bruisings in the neck. That is nothing to be concerned, but we really don't want to have any hematomas or things like that. So we really have to worry. It's just about a surgery concern. We really have to take care of the coagulation. In those autonomous nodules, we really have to take care of the thyroid function and the use of methimazole to avoid thyroid storm and things like that.
Very good. What's the minor nodule that you already treat? What's the minimum size that you already treat? Because I treat once or twice a patient with 3 centimeter nodules, but this nodule, it's not huge, but the patient were not comfortable with it. so we treat, and the patient is very happy, of course.
Well, it really depends. I have one nodule that I show in my lectures that is on a very thin and young woman, very in the isthmus. So the nodule was not that thick. So the volume was just a little over 1 cc, and it was very troublesome for her because it really showed when she swallowed. So it was not about the size, but really about the position. Another thing that we can treat more than one nodule in that patient. For example, we have one huge nodule, one benign huge nodule on the patient, and she accidentally have one other benign nodule on the contralateral side. So why not treating the smaller nodule that it's benign at the same session? You can treat both nodules. So I have already treated some benign nodules that are not very small, very large, 1.5 centimeters, because of the opportunity. As I'm going to treat the larger nodule, I would take care of the other nodule too. And that small nodule also counts on our case literature. So the mean volume of the nodule will end up decreasing, but we actually wouldn't treat the patient for that specific smaller nodule, but we end up treating that nodule,
I want to hear from you and from Higino. There is a question that many colleagues have doubts. How do you treat mixed nodules? If you aspirate before, at the same time, do you perform chemical ablation with ethanol, or do you just aspirate in the same time and perform RFA? How do you choose the patient that will to treat exclusively with ethanol or with ablation, RFA in mixed nodules? How? And I want to hear your thoughts and from Higino also.
Higino, go ahead.
Okay. Depends on the proportion of the cystic part of the nodule. If the nodule has more than 50% liquid part, usually I do first the ethanol ablation, and I will use the RFA ablation after the ethanol ablation. But you can do it in the same time too. And if the cystic part is small, you can only aspirate the liquid during the RFA ablation and do the RFA in the rest of the nodule. You need to remember that the radiofrequency ablation does not work in the liquid part. So if you ablate the liquid part, it will not work. So you need to aspirate the liquid when it's too much to do the radiofrequency ablation, right?
Yeah. If you have like a 40% liquid portion of the nodule, I would advise to aspirate the colloidal part of the cyst and inject a little bit of saline, or if you just to see the edge of the cystic part, so you can really get that area and ablate the edges of that cystic area. Because the colloidal part of the nodule, when you ablate, as Higino said, you get, because there is some protein inside, you get some crust, and you get some things around the electrode that avoid you, that makes a little bit difficult to ablate the other areas, because you have some crust around the electrode and the energy doesn't go very much, as happens to our bulvi. If you got a lot of crust, you cannot dissecate or cut with the bulvi. You have to clean the tip of the bulvi. The same thing with the electrode. If you have a lot of crust, you have to take the the electrode out, clean, and go back in. So sometimes aspirating the fluid is better, and re-inject a little bit of saline just to see the rim of the nodule. Okay. Wow, we had a lot of questions. Wow, our audience was
some.
Wow.
Okay.
Guys, have you ever faced a bleeding during RFA ablation, especially in mixed nodulus? I have once or twice a bleeding inside the liquid part of the nodule. Do you have already this, and how do you deal with?
Well, you do have a bovie on your hand, and
yes,
ablated until you stop it. If you see a vessel, if you see a vessel that is going on bleeding, try to get that vascular ablation technique that we use it, and try to get that vessel. But I never had one case like this yet. All those cases we are all going to have at some point. It's just a matter of the number of the cases we do. Sometimes
I had one case, actually one with more it's a more bleeding, and but we exactly what what you said. You have the tool at your hand to solve the problem. That's the tip for when it happens. You have the tool to solve the problem.
Yeah, sure. Wow.
Well,
guys,
let me. There's a question from the audience, and I would like to hear about you. When you need to repeat the ablation, how long do you wait for the second ablation?
Well, I never repeat the radiofrequency ablation before 6 months to 1 year, because we can experience some decrease in volume up to 6 months. So I really think that we should wait and see how the first treatment really decreases the nodule, and then if needed, we can do the second one eventually. Because this is one question that we didn't have an answer yet. What result is a good result? It is some magic volume reduction rate that we may achieve. For example, our series that we are publishing, we achieved reduction rates a little bit over 80%. That is very good around the literature. And as we have the first cases and now our late cases, but 80% is a fair amount of reduction. So if 80% is our goal, or is solving the neck problem, the swelling problem, and the patient's fine. Because if the nodule, for example, is still a huge nodule, it decreases 70%, and the nodule is 2 centimeters large, and the patient feels no complaint, doesn't see the nodule, and the nodule has no vascularization, why should we treat the nodule again? The nodule is not growing, the nodule has no vascularity. Why treating the nodule just to get it smaller? Do we need to get this nodule below 2 centimeters, below 1 centimeter? We don't have a number for that. I track, I tailor my cases to the patient's desires. So if the patient is comfortable and feels no more discomfort or static problem, for me it's good. It's a case of success.
What do you think, Erivelto? When you need to repeat the ablation, how long do you wait?
Oh, at least 1 year. Actually, I have 2 cases that we already redone the RFA. Both of them know previously that we'll need a second section. It's very important to do it to the large size of the goiter. So when the patients came to my office, I said, "Oh, there is one section will not enough for your nodule. You need at least 2 sections." And the 31 that I'm programming the next RFA, doing the ablation was not so effective as we suppose. So we will redo this in a few months. That's it.
Yeah. I just now saw a question that Dr. Randolph asked about withdrawing the needle as I did it. That is actually a good question, because the technique that was described, it was the moving and shot technique. So you shot, move, shot again, move, and shot again. I think this is the safest way to start your first cases. But as you get comfortable with doing the procedure, and if you see the whole electrode through the nodule, you can get comfortable retracting the nodule, the electrode through the nodule while ablating. And so you can retract and see the impedance at the same time and retract. The only thing you have to really be concerned is to see the needle at all times. Otherwise, you can start retracting and end up with the electrode tip in the subcutaneous with the electrodes activated, and it may get some burning on the subcutaneous and the skin. So if you're not comfortable, you're not seeing the tip, stop immediately the ablation. But if you are comfortable seeing the needle, there is no problem retracting and leaving the area really ablated, okay? But it's a very important question.
And never forget to take out your foot from the pedal.
Yeah.
Before you take out the needle. It's a very important.
Yeah. And for most surgeons that are used to those bipolar on the bovie, that we step on the switch and the bovie is activated, you take out the foot and the bovie stops immediately. Radio frequency, it's a little bit new, because you step once and you activate the tip, and you have to step twice to deactivate the tip. So you really have to control your foot switch. So it is important. So you step once, you activate, step twice, and deactivate.
Yes, very good. And Higino and Leo, have you ever treated intrathoracic goiters by RFA?
Yeah, that is very interesting, these questions, because when you experience radio frequency, what happens is when the nodule decreases, it not only decreases, but it centralizes. So the nodule decreases from the lateral to the center. So if you cannot treat for example, the substernal part of the goiter, when you treat the cervical part and it decreases, it will pull the substernal part of the goiter into the neck. It also, this effect also happens when you're treating very large nodules, and for instance, you have some areas that are very close to the dangerous triangle, close to the nerve. When you treat that, you leave that area untreated. You don't mess with the dangerous triangle. So you treat the whole nodule except that part. After 6 months, the nodule will decrease, and that area close to the dangerous triangle will move away from the dangerous triangle, and you can get back to that area again and treat it safely and treat the whole nodule. So in those cases, a two-staged treatment might be advised. Okay.
Higino, what do you think?
Higino, you're too far. We're not hearing you.
You hear me now?
Yeah.
Yes.
Okay. You need to realize that you can't treat directly the thoracic part of the goiter, because the ultrasound is not, we are not able to see the needle with the ultrasound. So the way that you do it is to do the cervical, the neck part, and wait for the interthoracic part to move to the neck and do it again, as Leo said.
We call this the iceberg technique. When you treat the upper, the part below will go up.
Yeah. Well, guys, I think we just covered about everything.
We have no more. Hey, guys.
We have nothing more to teach.
Yeah.
Just a simple. Let me put you guys. What is your opinion for RFA in terms of treat micropapillary cancer? Have you ever treated?
Yeah, we are definitely moving forward on that. We are seeing a lot of papers, and this year we had some 5-year follow-up, 2 papers on 5-year follow-ups on micropapillary carcinomas. There was one paper that just released from the Chinese group that treated those T1Bs, micropapillary carcinomas, those papillary from above 1 centimeters with excellent results. So we are really definitely going to hear a lot about this. And but we have to be extremely good on doing those benign nodules before moving to those cases, and before moving to those lymph nodes to the parathyroid. We have to excel on those benign cases so we can move forward. It's as much as everything in medicine, we have to excel on we have to climb the ladders as we go.
So, Dr. Rangel, you know, we're an hour and 15 minutes in. I know we can have a lot of these questions, but I just want to let everybody know that we're going to be putting some training material together that's going to be offered that as part of your, as you incorporate RFA, and as part of if you incorporate it through RGS Healthcare, you're going to have a lot of access to these training materials that we're going to put together for you guys, because we could sit here all day and really go over all of this. But one last question, and it'll be the last one before we sign off today. And we're going to be doing more of these. We're going to be doing a lot more of these because I think they're really good interactive way to learn and to grow interest, the way we could save some thyroids. But the last question I wanted to ask you, Dr. Rangel, then we can sign off, is that can you please address or reiterate a little bit more of the hydrodissection technique and its importance?
Yeah, and Rudy, as much as I like this kind of meetings, I really would like to have you all in Rio, so we can have some farofa and some brigadeiro that I know you like, and some huge meats that people would really like.
Yes.
I really would like to invite everybody to our course in Rio. It is a good opportunity. We can do these cases with you on our sides, and you can experience doing this procedure and have this 3-dimensional aspect of the nodule. Is very important to know this 3-dimensionally. And talking on hydrodissection. Hydrodissection, it is an important part of the procedure, because you saw that how comfortable the patient. We are using a bovie. We are burning that nodule. If the patient is not comfortable enough, the patient will complain of pain and will demand you to stop the procedure. So the Koreans, in their first experience, their limitation for the procedure one of the motives for stopping the procedure was actually patient not bearing the pain, and they interrupt the procedure. Doing hydrodissection and really take care with lidocaine and 5-DW, I don't see a reason not to continue the procedure and not taking care of the whole nodule. I've never had to interrupt the procedure for pain complaints. You know, we have in one of our courses, we had one guy with severe back problems that could not bear the position for long. So we stopped the procedure for a little bit, and the guy moved a little bit and moved with the pillow, and then we got back again with the procedure. So it was not really a thyroid pain problem, it was a back pain problem. And so this is how important I think hydrodissection. Hydrodissection prevents pain and prevents complications. You can hydrodissect some nerves, you can hydrodissect the vagus, the carotid, the trachea. For example, sometimes ischemic nodules or nodules very close to the trachea, you can go with the needle through the thyroid and have some liquid, some 5-DW between the thyroid and the trachea, so you can really take care of the nodule. So it's another thing. So you have to be very handy and resourceful. So I think hydrodissection is an excellent tool to learn and to master.
Perfect, perfect. Well, Dr. Rangel, Dr. Volpin, Dr. Steck, thank you so much for putting this together for us here in the US. I think it was extremely, extremely educational. People got to see how firsthand how it is, how safe it is to do this procedure. This procedure was done in the OR because those are the rules in Brazil, but here in the US, the way you're teaching it is how they're able to do it in the clinic. Safely. So a lot of doctors have gone through your training program, Dr. Rangel. All of them have been excited. I can't wait for us to be able to travel to Brazil and continue that program, and as well as the advanced training programs you are working on behind the scenes right now. You know, so once that's going to be great as well. But thank you everybody for attending. You know, you get a follow-up email from us. And we'll let you know when's the next one, and we'll go from here. But thank you very much, guys. Thank you.
Okay. Good, guys.
Thank
Have
you.
a nice weekend. Hope to see you back. Hope to see you in Brazil and Rio. Bye.
Bye-bye.
Thank you.
Bye.
Bye-bye.
Thank you. Thank you. Bye-bye.